These are my financial disclosures. So I will go briefly over the endpoints and goals of hepatitis B therapy, the standard options for current options for hepatitis B therapy, PEG monotherapy, and entecavir, tenofovir. Some of the data about the combination of PEG and oral therapy, the long-term outcome as we see today, and during my presentation I will go through some of the limitations of the current therapies to set the stage for the next speaker. So overall, all the guidelines are very much similar in the way they suggest who should be treated. I think the overall idea is that the overall aim of all these guidelines, European guidelines, American, even the new guidelines from US and Asia Pacific, is to identify those with disease progression, phase 2 e antigen positive disease or phase 4 e antigen negative disease, and to improve the survival of these patients, antiviral treatment is indicated. So there is a strong link between survival, progression of disease, and indication of antiviral therapy. And indeed, 90% of the patients in these phases currently followed in liver centers everywhere are already on oral therapy for this specific reason. For the same reason, phase 3 in active carriers, there is not really indication of antiviral therapy, and only few of the phase 1 patients are on therapy in few selected patients. So this is really a summary. So aim is to stop viremia, to reduce complications, to improve survival. And option 1 is interferon. We all know how interferon works. From the biological point of view, potentially the best antiviral therapy available today. Option 2 is oral therapy. Once again, a very strong inhibitor of DNA replication, not really doing almost anything at the cccDNA level or the RNA levels for antigen production. And potentially option 3, the combination of these two drugs. Option 1, interferon, has been around for a long time. We know 20 to 30% of the patients, either e antigen positive or negative, will have a sustained immunocontrol, which is basically the inactive carrier state. And then the immune system over time, in 30 to 40% of these responders, will achieve the best possible outcome, which is S antigen clearance. We know that responders will have a decreased risk of cancer and development of cirrhosis, and the major advantage is the short-term duration of the therapy. However, there's a major limitations, side effects, injection, and the 30% only of the patients responding. So over the last 5 years, many studies have tried to improve the efficacy of PEG interferon by selecting, before starting therapy, the good responders. And indeed, I think now, yes, we do have some baseline prediction scores that are able to overall identify good responders from those who do not need interferon. We do also have a quite strong week 12 stopping rules, at least for some genotypes, and these are based on S antigen levels, can be very effective in identifying who should stop therapy. We also have some data suggesting that for genotype D, e antigen negative, you need to extend duration of therapy, although this is very complicated for side effects. On the opposite, I think we don't have so strong data about genetic predictors of interferon response, and NUC pretreatment does not appear to respond to increase response rates, and the de novo combo is working really in a very selected patient genotype A. Option 2 is oral therapy, third generation NUCs. These are the 5-year data in entecavir monotherapy naive population across the globe with different countries, different viral genotypes, different genetic backgrounds, 1 pill a day for 5 years. I think there is no really any major comment to make. 95, 100% suppression rate. Very easy, very simple, very effective. The same is true for tenofovir. Now we have 5 years data, but the picture is the same, 95 to 100% response rate. independently of all the baseline variables. So very effective, very easy, with 85% of the patients achieving normal ALT. Although these numbers are very, very good, we do have some limitations. In high viral load patients, with or without resistance, still we do see partial response despite entecavir tenofovir. We do have maybe the most important issue, and the next speaker will cover this issue. Despite a full suppression of viremia, the serological responses are very limited. So we definitely need new stopping rules. And because of the low response rate, serological response rate, the duration of therapy is long, with all the issues related to the long duration of therapy. Recently, we have reviewed, together with Harry Johnson and others, the problem of safety. Entecavir and tenofovir, but this is really reflected by the tenofovir data, this slide. And just to make a point that although the registration trials has been very reassuring, real-life studies suggested tenofovir could be problematic in terms of renal safety in some of the patients. Indeed, 8 cases of tenofovir-induced Fanconi has been demonstrated, and the longer duration of tenofovir and the older patients are high risk of developing renal toxicity. And the most important message is really of this review was that we need more data. I think this has been not really looked carefully in the last 5 years. We need more data with very strong and very precise definitions for tubular disease, for example, to be ready to eventually use the new drug which will become available very soon, which is TAF. As you know, TAF is a sort of a second-generation tenofovir. It's been developed to avoid the off-target effect of tenofovir that was activated in the plasma. This led to accumulation of the active drug in the tubular cells. So this is not the case for TAF, which is activated only in the hepatocytes. There's been 2 phase 3 recently published. Just to make a long story very short, a similar efficacy compared to tenofovir, but a better safety from both the bone issue, glomerular point of view, and also from a tubular point of view. This drug will be available very soon, so this drug will be available to solve the issue of safety in some of the tenofovir-treated patients. Option 3 is the combination of PEG and oral therapy. There is a strong biological rationale. You combine a strong DNA inhibitor with an immunomodulating drug. This is a systematic review. If you want to use oral therapy to improve interferon response, it's not really working very well, maybe in these selected genotype A patients. If we want to use interferon to improve oral therapy in the naive population, we do have some data, but still very few studies. Maybe the most promising condition or strategy is to use interferon to improve oral response. Oral therapy response means S-antigen kinetics. These can be used switched to for antigen positive patients, data from China, or add-on interferon to antigen negative patients, data from Europe. Unfortunately, again, as usual for interferon, 20–30% of the patients will do very well. Most of the patients will not respond to this strategy. When to stop oral therapy, this remains a major problem. European guidelines, but also the new American guidelines are really suggesting that the best stopping rule is functional cure, which is not really anything new, S-antigen loss, anti-yes seroconversion, independently of the serology, and this is a very safe stopping rule even for cirrhotics. There's been a lot of question or discussion about whether you could stop before S-antigen loss. This systematic review, including 14 studies, 700 patients initially antigen positive, show that only 50% will have a 3-year off therapy virologic response if you stop before S-antigen loss. And this systematic review was not able to identify any predictor to identify this 50%. 50% virologic response, 76% biochemical remission, 1% only of S-antigen loss. For the e-antigen negative population, again, a systematic review from George Patodiri showed that If you combine 17 studies, almost 1,000 antigen-negative patients, you stop oral therapy before S antigen loss, then only 30% of the patients after 3 years remain in virologic suppression, and this is not a very strong definition of virologic suppression. It's below 20,000. We normally use below 2,000. 50% biochemical remission and 1% only S antigen loss. So again, in my view, this is suggesting that today we should continue oral therapy, waiting for new stopping rules. What's about the long-term clinical benefits of these drugs? I will concentrate on entecavir and tenofovir. First of all, the first endpoint is histology, entecavir data, tenofovir data, but overall, the most important data are these data from tenofovir, 5 years data, liver biopsy baseline, year 1, year 5, a significant regression of fibrosis, overall 80% of the patients, a significant regression of fibrosis in those with baseline cirrhosis, and if you have another cause of liver disease, you will not see a regression of cirrhosis despite full suppression of viremia, and this is a very important point. What's about decompensation? If you start with a compensated liver disease, a compensated cirrhosis, what is the likelihood to have a decompensation event during entecavir tenofovir? Basically, decompensation is fully prevented by entecavir tenofovir as long as hepatitis B is the only etiology, is the only cause of liver disease. For liver cancer, the situation is completely different. It's different because the biology of cancer is different. It's also different because it's much more complicated to develop studies, control groups, as all cirrhotics have been treated since 1996. So if you want to look for control group, you have to go back to the 60s and 70s, early 80s, and I'm sure those patients are not the patients that we see today. So to make a long story short, if you want to put together the 4 propensity score studies from Asia and the US, these 4 studies clearly showed an advantage and reduction of cancer risk in those treated compared to those untreated. If you move from US and Asia to the model which is different, Europe, multi-center study, mainly E antigen negative genotype D patients, you don't see, and all treated only with entecavir and tenofovir, 2,000 patients over 5 years, you don't see any major reduction of cancer risk in the first 5 years in those without cirrhosis or in those starting with compensated cirrhosis, as compared to historical controls. But after 5 years of continuous therapy, you start to see a decline of cancer risk in cirrhotics, 1.1% compared to 3%. And however, you don't see a change in non-cirrhotics, suggesting that actually this is a very difficult group where you want to reduce liver cancer. Survival, the most important endpoint. That's why we are treating our patients. If you look to Hong Kong, there is clear evidence that the entecavir treatment is able to reduce liver-related mortality, and also some evidence of all-cause mortality. If you go from Asia to Europe, the PhD study, 2,000 patients on entecavir and tenofovir for 5 years, now actually 8 years, and you look at the liver-related death, and unrelated death and liver-related death in non-cirrhotics, you see that most of the patients died for non-liver-related death. The few patients dying because of the liver complication all die because of cancer. If you look at cirrhotics, 50%, which is 3%, die for unrelated liver-related death, and 50%, which is 3% for liver-related, and 2/3 again for cancer, and 1/3 for other complications. So 3 messages. First of all, the 5-year survival of cancer patients on entecavir and tenofovir is excellent today, with what is available today, more than 95% survival. A significant proportion of patients, comes from unrelated causes, non-liver-related causes, And HCC is the major cause, if not the only cause, actually it's the only cause of death in non-cirrhotics and the major cause of death in cirrhotics while on entecavir and tenofovir. So to summarize, ladies and gentlemen, I think that PEG interferon option 1 can be used for some of the patients only, and actually is effective in few patients only. It's very effective, but only in few patients. For most of the patients, option 2, which is entecavir and tenofovir monotherapy, is very effective. As a monotherapy, more than 95% suppression of viremia, 5 years, but now we have almost 10 years experience with entecavir for naive patients and 9 years on tenofovir. Option 3 is the combination. Yes, you can use a combination, although this is not recommended by any guideline. In my opinion, you could use in very selected populations, mainly to foster S-antigen kinetics in those already on oral therapy. TAF will be available very shortly, could be useful in some of the patients. These drugs or these strategies are not only effective from the virological point of view, they're very effective from the clinical point of view. You can fully prevent clinical decompensation, improve portal hypertension. Liver cancer is the only complication, is the only cause of hospitalization, the only indication for cancer, for transplantation, and the only reason really for the reason why our patients on oral therapy are dying today. Overall excellent 5-year survival today on oral therapy. So do we need new strategies, new drugs? Yes. Our next speaker will expand this issue. In my opinion, we still have to reduce the liver cancer. I'm not sure we need new drugs to reduce liver cancer. Definitely we need new strategies. The most important strategy is to start early. Early treatment is crucial from my point of view. And of course, we need new strategies to improve S-antigen loss rates, which is basically to improve functional cure. Thank you very much for your attention.